I'm going to introduce our next speaker, Dr. Ahmed Jakda. Dr. Ahmed is the Provincial lead for OPCN, which is Ontario Palliative Care Network. And he will be talking to us today about the provincial policy for establishing culturally sensitive palliative care.
Thank you very much. And I really want to thank our previous speakers for their informative talks, and especially our international guests who have arrived to give us their insights. And I really enjoyed this Ahmed in front of me. My name's Ahmed as well, but this Ahmed in front of me, his examples, because they really give us a sense of practical things that we could apply. So I also want to thank the planning committee in particular, as well as Leslie, who oftentimes the coordinators have to deal with all these specific nuances, and it's always difficult, but my thanks to her. There is a slide deck that's there. I'm going to have to cut it short, not because the previous speaker went over their allotted time, but because as I was sitting here, I've been sort of swimming with all these ideas around what it means to speak at a conference like this. Naturally, I have an administrative role as the physician lead for the OPCN. Beyond that, as a palliative physician, also being born and raised in the West, but then of course the fact that I'm Muslim. And so, what does this mean for me as I speak to you today? So, but before we get to some of that, I thought it was important for me to just start off with busting some myths, because it's always important to make sure we're on the same page. So if you have your pens and papers, make sure you write this down. This is probably the key learning points from the day today. The first is that Muslim men had beards before it was cool. So there was this experience that I had in Kansas City about 10 years ago, and I was walking down the street, and there was this young man that walked towards me, and he said, "Hey, cool beard." And I said, "Hey, thank you." And I didn't realize that it was actually a hipster type of thing that had developed. And so to me, that was like, wow, the coolness came up to me, and so now I am the cool. And so that was really exciting. The other myth I wanted to bust, and what we'll do is I'll ask a question, and then I'll bust a myth after that. So the question is, two men, Muslim men, enter a. See, you're wrong. Well, this was the point of it, because you would think a bar, and I think one of our very first comments today was the idea that the Muslims are very heterogeneous, and certainly I have met Muslims who drink, of course, and there are many Muslims who don't. And so the idea is when you're interacting with a patient of a Muslim background, certainly you have those concepts in your mind, but beyond that, you still have to ask those questions in a way that's respectful, because you might be dealing with a patient who's suffering from alcohol withdrawal. You might be dealing with a situation where family doesn't know about it. These types of things are really important to be aware of. And so you have your concepts, and then you have your actual practical patient experience that has to be tailored. So to finish the story, two Muslim men walk into a restaurant, and they turn to each other, and on the menu is a shawarma, and there's also chicken biryani. So the question is, do Muslims like chicken biryani more or shawarma more? So if you're in the shawarma camp, put your right hand up. See, these guys are playing it cautious now. I know all of you. And then the chicken biryani camp. Yeah, okay, good. So the chicken, you're all wrong again. But having said that, shawarma tastes good, but chicken biryani will kick it any day. So that's important. And then the last myth I wanted to bust was when Muslims come to visit a Muslim patient, they come in the bus loads. Is that myth or is that reality? That is reality, yes. You're all right. Okay, and so that one is definitely true, and I'll reference a hadith that Prophet ﷺ said that when a Muslim visits a sick Muslim at dawn, 70,000 angels keep on praying for him until dusk. And if he visits him in the evening, 70,000 angels keep on praying for him until the morning. And so there's a motivation to visit the sick. The idea of providing empathy and compassion is very central to Muslims. And so it's an obligation, really, in the sense of trying to to visit another person that's sick. And on a personal level, as a Muslim physician, to me, if I sort of keep this intention in my mind as I'm seeing patients to provide that compassion with this hadith as a central tenet of my action, then my hope is that I'll receive that reward as well. And so that's what motivates me on a personal level. So now that I've wasted 10 minutes of my time, or not wasted, I hope, I'm going to sort of move on to a few ideas. So I have no conflicts of interest. Nobody wants to give me any money, so that's written there, so for you have it. So I had a couple of objectives there, and I might just refine them a little bit as we go forward. But I do want to talk about the Ontario Palliative Care Network and connect that with some of the work that we're doing within the province. And so the OPCN came into existence in March of 2015 or 16, somewhere around there. I'm looking at some of my colleagues who might have a better sense of that history, but it was a couple of years ago now. And the driver for this was to realize the idea of a coordinated system within the province to deliver palliative care. And of course, that takes into account all Ontarians, whether or not you're from a First Nations background or a Muslim background or whatever background you come from. And so how do we create those processes to be sure that we're serving the needs of all people within the province itself? So we are the principal advisor to the ministry for all things around palliative care. We have an accountability to the province and strong relationships with our regions who all have palliative programs, and our relationship is based on accountability frameworks, performance, and quality as well. I've put a few slides in here which we might get to around the metrics that we measure to see how we're performing. And this is all work that's happening real time, essentially, to the extent that we're just now completing our action plan and also formalizing our quality standards through Health Quality Ontario. When it comes to the regions, that's really where our success lies, because we can do all the planning that we want to, but if we're not actually seeing that being realized and being informed and championed locally, we won't be able to get as far as we want to. And so, speaking back to Ahmed's earlier point around the idea of trust and having conversations and the body of work that needs to happen when it comes to connecting Muslim needs, that has to happen at some level on a local level, because you'll see that that's where the experience is most rich. So the Ontario Palliative Care Network is a combination of a number of organizations. The four big organizations are the Local Health Integration Networks, Cancer Care Ontario, Health Quality Ontario, and the Quality Hospice Palliative Care Coalition of Ontario. So these four partners sit at a central table and make decisions around the planning and ensuring that we're meeting the needs that the ministry has asked of us. So my thinking is I'm going to sort of stop at this slide, even though we have a few more slides. So we've gone through a number of regional engagements and action work to try to settle down what is it that we're trying to accomplish within this province. And so these are the sort of 8 or so areas of action that we want to focus on. And obviously beyond these specific titles, there's metrics and other deliverables that sit under here. But I want to just stop at a few of them, just so that I could try to make the connection between this as well as how it might apply to Muslim patients, as well as perhaps infuse it with some of my experience as well. So the first one is enhancing patient and caregiver engagement in palliative care. And I think this is a challenge, because in my mind, how do we engage the Muslim community in conversations around advanced care planning and planning for the future? You know, personally speaking, and as I was listening to some of the theological discussions previously, I was trying to create a framework in my mind in terms of how I approach these things. And this has been the biggest challenge, one of the biggest challenges in my professional experience. And that is how do I approach patients of a Muslim background, despite the fact that I am Muslim as well. And so the assumption would be that because I have that knowledge and that background, and Ahmed is clearly better at it than I am, but I find myself very nervous, in fact, when I'm entering a conversation with Muslim patients for a number of reasons. And one of the reasons that I experience that is because oftentimes people will involve me because they know me through somebody. And there's this expectation that perhaps they're being told something by their healthcare team that is not necessarily true. So sir, you have cancer and you have this disease that's terminal, and we're going to be talking about this. And suddenly I'm sort of pitched into this situation where I'm walking in and they're almost looking at me with this expectation to say, can you correct this healthcare team? Because clearly they have it wrong, and we're Muslim, and so we know what's going on here, really. And so, and for me in that situation, it's very difficult because I have to balance their expectation of me as well as trying to not sort of step on the toes of the healthcare team. And so this has happened on many occasions. The other component of this is also oftentimes involvement of Islamic scholars and imams and people that have been brought into the conversation to help understand what the next steps and options are. And so Asim did a great job at talking about the theological concepts and implications of that, and those conversations are necessary to happen. In my mind, the massive gap that exists between that and the practical actual happenings that are there is always the challenge. And so sometimes I'll be in a situation where the imam is not fully aware, and this is a gap that exists because of our inactivity, at least my inactivity in educating that population. But how do you ensure that they know the fact that there's futility here in some sense, and how can they help to convey that message? And that's the big challenge. And so I'll give you a really simple example, and there's a few of these I have. But I was called into Scarborough General Hospital about a year ago, and you know, I entered the room. The auntie, we'll call her auntie, she was on her deathbed, essentially connected to machines. There was some family connection, and so I was there in that capacity. And I was looking for her son, and her son had gone to speak to the imam, and I caught up with him in the lobby of the hospital. And so, to me, it was very clear that her prognosis was months, if not days, and I would be surprised if she were to come out of this alive. And so how do you convey that message, respecting the fact that they want to hear something else from you completely? The message that the imam had given the son was, yes, continue with the treatment, continue with the interventions, and this is the best thing, and this is the way to go. And you know, there's gradations of imams. There are people that have some knowledge, there are some people that have more knowledge, and then there are the people that have strong authority within the community. And I would say this person was of a person who had strong authority. So I walked into the lobby, and this is what he told me. So I said, listen, we have to go back to speak to this person, because clearly my opinion in this matter wouldn't override that scholar's opinion. And so we went back to the masjid, to the mosque, and we sat down with that scholar, and we had a conversation. And it's a difficult position for me to be in, because within our culture, the scholar has a lot of influence, rightly so, but at the same time, your healthcare and professional experience has a bearing on this. And so how do you communicate in a way where you're being respectful, but also telling that scholar, you're actually completely wrong, you know? And so, and that's the challenge that I've had. And so sitting there, I explained, you know, this is not likely to happen in my experience, this is what happens usually, etc. And so eventually that scholar said, you know, I was just trying to give them some hope. And I think somebody spoke about hope. I think it was Ahmed. And so this idea of how do you share that information in a skilled manner while also being sure that the hope is maintained. And the conflict that the paradox actually that exists in my mind at least is Muslims are aware of death, and we're told to plan for death. And we do that in many ways. But when we are actually faced with decisions around death itself, we very much withdraw and cringe around that. And that's the conflict and the paradox that exists. And so there has to be communication between these concepts today and the actual scholars that are advising, so that there is some consistent message that is there. And I think there was somebody who spoke earlier about the idea of a patient who's dying, who's not actively Muslim, who's not reading Quran, etc. There's a natural tendency to reach out to that community because you want something to hold on to. And so unless that community is prepared to respond in a way that's generally consistent, it's difficult for us to avoid these major conflicts that can exist. I've been a part of capacity and competency boards and called in to speak about, you know, my opinion around patients. And there was one situation where a patient had been in the hospital for 2 years, and I don't kid you, I picked up, version 6 of the binder, I think, and when I was asked to be involved, and they had been on dialysis for that long, and nephrology, the kidney team wanted to remove that hemodialysis and let her pass away, but the daughter would not let her, and this was a family from Kosovo, and sitting there and trying to sort of give my opinion in this situation is a very challenging thing, because you have a daughter who's sitting there and she's wanting to continue that treatment, and as a Muslim palliative physician, I'm basically saying there's no future, there's nothing of value here, because she's not awake, she's not alert, you're just continuing this for no value at all. And so some of those personal challenges I wanted to share with you, because I want to sort of debunk this idea that it's easy, or because you have that knowledge, it's easier, because I don't really know that that's what my experience is. The other thing I wanted to talk about, so I had actually written down a framework while I was sitting there, and a lot of this has been touched on, but I want to sort of encapsulate it a little bit. There's Islamic law, and there's theoretical concepts that exist, and then there's the variable interpretation that exists among the scholars that interpret that. And then there's the individual understanding that exists beyond that. So you have this whole conversation that's happening at this level, and then there's this massive gap between that and the actual application. And you have a patient, and a patient is surrounded by family, and in many instances, family members are very quick to become involved without understanding the Western concept of autonomy. And so autonomy has to be something that has to be manipulated a little bit. And so you can't go in there and say, and I've been in a situation where my mom was in the hospital, and a doctor speaking to my mom who doesn't speak English, and I'm standing right there, doctor's son, and that doctor is sort of ignoring me, which I respect, because he's trying to maintain autonomy, but it doesn't work, right? So you have to kind of manipulate it a little bit so that the situation works for everybody. You also have to try to understand the motivation for the family that's involved. Many times an elder son will say, well, this is my job, this is my responsibility, I have to fight the system to be sure that my loved one is receiving the best care possible. And the idea of an end to treatment is a very difficult thing for them to accept. And so how do you have that conversation? That's always a challenge. And then the power struggle between the healthcare team and then the religious scholars that can sometimes exist, because that's something that has to be carefully constructed, and there has to be an organized manner in terms of how those conversations are happening, because that can be rife with difficulty if there's disagreements that are strong there. So, I was writing down some ideas around how I would approach it. I think some of the principles that we already follow in Western medicine are applicable. And so, what does the patient want, and how do you ask that question? What does the family want, and how do you figure that out? What does Islam say about this, and to what degree does that influence this situation that you're in itself? And then trying to balance even we have our own palliative care culture. So for example, we don't give fluids at the end of life, right? That's our palliative culture. You ask any palliative practitioners, that's what they'll say. In most cases, we don't give fluids at the end of life. But a family wants that. And how do you balance that? And perhaps you have to make exceptions in those situations, because you have to be sure that the patient and family are happy as well, given the circumstances that they're in. So I think I have a few minutes left, and I wanted to stop there because I really wanted to take questions if there were any that are out there. Everybody's hungry, I think.
Thank you. Thank you for the myths, and thank you for your comments. My specific question is around the OPCN's I guess, contributions at the moment, particularly for the Muslim minority community. Are there any resources that you're developing to help imams, to help Muslim patients, to help doctors looking after Muslim patients, to explore sort of Islam and palliative care? Because I think this is a large area, and I'm not sure what OPCN is doing, or perhaps what the broader Canadian network is doing. I'm aware of a few initiatives, but not specifically what your network's doing.
Yeah, no, there's nothing specific to the Muslim population. In terms of priority populations that are outstanding beyond the general adult population are pediatrics and First Nations. And so we do have a lot of resources that exist around that, particularly First Nations. And so we're developing culturally sensitive things around that. But I think something like this would get accomplished only by way of bringing together a coalition of the willing, meaning how do we practically form resources so that we're able to teach and sort of reference people so that they know how to accomplish these things. And there's a bit of work that I've done on this that's been stagnant over the past few months, but my hope is that we could create a partnership with interested people to develop that, because it's a very niche type thing, right? And you know, from a system perspective, it's also unfair to a degree to focus on a particular group like that and exclude others. So,
thank you for the presentation. Moving from that and kind of putting your presentation together with Ahmed's and Ibrahim's before. You know, some of the advanced care planning is, we can talk about Muslim patients, but it's actually because we don't have conversation spaces in society about the end of life, right? So, and like in Chicago, I know that there's a Chicago End of Life Care Coalition, I believe, that puts on things called death cafes, where people come together and have conversations, right? And sensitize individuals that this is part and part, all of us are going to die, we should talk about these, and people then share experiences in hospitals that are somewhat cathartic for them. So I don't know if there are similar things here in Canada where we're actually having somewhat making it culturally okay to talk about these things. Then you can talk about advanced care planning. But if that doesn't exist and there's no traction, because people, as you said, and in the quotes that you brought up, this is just totally foreign. It's not, you know, indigenous to our culture.
Yeah, there are death cafes that happen in this country as well. You had your last slide was the Speak Up campaign, which is a Canadian initiative that looked at normalizing advanced care, and it was the idea of speak up about end-of-life care. And so those things do exist. Specific to the Muslim population, I think it hasn't touched that community yet. And I think that's something that, you know, as responsible people, we have to try to move forward, because unless we have those early conversations, it's a challenge. And that's the paradox in my mind, because we, as Muslims, we have ayah, we have du'as, we have prayer that speaks about death every single day, and we do this. But if you actually sit down and say, if I sit down and I say to a Muslim person, let's talk about death and have you planned for death, there's some normalcy in that conversation. But if I sit down and say, have you done your will, and what would you do in this situation? It's completely outside of the box. Yes?
Yeah, as for the resource guide for physicians and others, the Ontario Multi-Faith Council, now called Canadian Multi-Faith Federation, of which I'm the vice president, we deal with chaplaincy in hospitals, jails, and long-term care facilities across Canada. And we have the Multi-Faith Information Manual dealing with about 35 different faiths. So that is available if you go to omc.ca. And you can order that for a nominal cost.
Thank you.
And that has all necessary information that for sensitivity.
Right. Thank you. So if there's a choice outside, we all know that the chicken biryani is the choice to go with, right? Okay. Thank you very much for the opportunity.